Hello, welcome to today's edition of the CalHIPSO monthly webinar series. Sorry, hold on one second. Today's presentation is on EHRs and the opioid crisis. A couple housekeeping items before we get started. All attendees to the presentation today have been put on mute, but there will be a question and answer portion at the end of the session. What we are asking listeners to do is to enter your questions into the chat box that you should see on the right side of your screen, and then we will be answering those questions as time allows at the end of the presentation. So to get us started today, I can't seem to move forward. Sorry, hold on one second. Lori, can you just do next slide? So for anyone listening today who is not familiar with CalHIPSO, I know we have a lot of folks today, some of whom are outside of California. CalHIPSO was founded in 2009 by a really unprecedented joint venture of the California Primary Care Association, the California Medical Association, and the California Association of Public Hospitals and Health Systems. CalHIPSO was the largest by provider census of 62 federally designated regional extension centers, and as such, our job was to help safety net healthcare providers to adopt EHRs and ultimately get to meaningful use. Next slide, please. So while CalHIPSO was originally formed to be the Regional Extension Center, we recently are starting to branch out into many other different areas. And as we say, as the provider needs have gotten more diverse, CalHIPSO has gotten more diverse in response. So while we are still doing some work in meaningful use, especially on the Medi-Cal side, we're also working in the macro quality payment program, and we're doing some other projects on diabetes data reporting, encounter data, and as we'll be talking about a little bit later, we are ramping up to start a large project to help providers onboard the health information exchanges. And across all the programs that CalHIPSO has done to date, we've helped a little over 13,000 unique clinicians in more than 1,400 provider organizations statewide, and providers working with CalHIPSO have earned just a little over $250 million through various federal incentive programs. Next slide, please. So today, for today's presentation, we are very excited to be joined by three members of the Electronic Health Record Association Opioid Crisis Task Force. And I'll give them just a brief introduction before we pass control over to them. So first of all, we're joined by Lee Burchell, the Vice President of Strategic Health Policy and Industry Affairs for the Allscripts Corporation. Lee Burchell leads the Policy and Industry Affairs function for Allscripts, including legislative advocacy and regulatory response. Her role includes speaking on behalf of the company's almost 50,000 ambulatory practices and 4,500 hospitals. Dan Seltzer, who's Senior Analyst for EHR Excellence for Meditech. Dan is responsible for clinical pathway development, and he is the lead author of Meditech Sepsis Management and Opioid Stewardship Toolkits. And finally, David Bucefaro, Senior Advisor for Foothold Technology. He's the Senior Advisor and an Information Security Team Lead with Foothold Technology, a New York-based company supporting human service providers across the country with a web-based electronic record, behavioral health electronic health record, and homeless management information systems. So we are very excited to have them. All three of these folks have been active in the EHR Association Opioid Crisis Task Force. And with that, we will pass control over to them. Take it away.
All right, perfect. Thank you so much. We appreciate it. This is Lee Burchell. I'm going to kick us off here. We wanted to give you a little bit of background as to who the EHRA is, just so you understand the context in which we work together. I think, Dan, you're driving, right? The slides? Perfect.
Yes, go ahead.
We are the trade association for electronic health record vendors. So most of our member companies are more broad than electronic health records, of course, in the world of broad health IT adoption. But that is what bonds us together. We work with hospitals and providers across the entire spectrum of care, from the smallest physician practices all the way up to huge health systems, critical access hospitals, post-acute, specialty practices, et cetera. So we bring a lot of different voices to the conversations that we have. We're entirely volunteer run. We have excellent support from some project managers from HIMSS, but as far as the work that we all do together, it is essentially made up of volunteers from our member companies who come together. Next slide. So we work together on a variety of topics. We are limited in what we can work together on. We cannot tell our members to do anything, nor can we make commitments for our members. We don't do that. We frequently are approached by people saying, can't you make your members do X? And the answer is no. And we also do not share information with each other that isn't appropriate in a trade association environment. But that still leaves a ton of stuff that we can do. And we, believe it or not, work really positively together. We all have good relationships with each other. We spend a lot of time on the phone. And we have, I think it's 9 or 10 work groups right now, might even be more, in the midst of a lot of comment process that we're in right now. Next slide. So we have, well, I already said this. All right, next slide. So we have 9 or 10 work groups. They span a variety of topics, everything from clinician experience, which addresses usability, to standards and technology, to public policy, to delivery system reform, wide variety. But our newest work group is the Opioid Crisis Task Force. So we agreed in our strategic planning sessions in late 2017 that we were going to establish this group, and began work in January of 2018. We have really great volunteer participants. This is obviously a pretty important topic that's generating a lot of industry conversation, as well as regulatory and legislative activity at both the state and federal levels. And so we've had really good participation levels from people. And interestingly, this has brought in people who haven't always participated in EHR Association activities before, like pharmacists and doctors, nurses, technical experts. We have a really nice cross-section of the work that all of us do individually within our company, contributing to the work that we're doing to try to help solve some of the Opioid Crisis Task Force or crisis challenges that are touched by health IT. So we have 3 subgroups. One is policy, and that is what I work on the most. My day job, as was mentioned, is heading up policy and government affairs for Allscripts. So this is a natural area for me to help with. We have a clinician impact subgroup, which is co-led by Dan Seltzer, who's on, and then Alan Staples, who is from Cerner, wasn't able to make it today. But that group focuses on where is the intersection between the clinicians who are affected by some of the changes that are happening in opioid best practices, in technology and regulatory limitations, and then with our technologies, so that we can make sure that we are providing guidance to the industry and to our members as to how our tools can best be maximized, what are some best practices, how can we translate work that is happening out in the industry into our products. And then our third group is the standards and technology subgroup. And this is where we look at what's happening as far as standards, technical standards, as well as requirements in legislation and regulation, so that our members can stay on top of all of that. There's a great deal of disparity. David will be talking about that a little bit. But we really are advocating for consistent standards-based approaches across the states to help lower the amount of work that goes into our support of our clients across the various states. Next slide. So today, Dan is going to kick us off, and he's going to talk about an implementation guide we produced. We've gotten some really good feedback on it, and then after Dan goes, David will talk a little bit about a minimum data set recommendation we have. So Dan, I'll turn it over to you.
Thank you so much, Lee. I appreciate it. And good afternoon, everybody. Great to talk to you. Our clinical impact subgroup has been meeting for about a year and a half now, and I've been privileged to lead a team of people who've been very passionate about doing something to make a difference in the opioid crisis. And when we, using the power of EHR technology, and when we first sat down to start to tackle this problem and analyze what the role of clinicians are and what the role of HIT is as it pertains to the opioid crisis, it was a big challenge for us. And we, about a year and a half ago, sat down and said, we started to brainstorm what can we do and what can we contribute to help hospitals and the vendor, HIT vendor community to make a difference in this space. We knew that overprescribing of opioids was a big challenge, but it wasn't just that there's multi-dimensions to the workflows involved in opioid prescribing, and we sat down to analyze what the best practices were in the space, and then think about ways we could apply that within the health IT space. There were a lot of guidelines that our team reviewed out there that offer guidance on how to use opioids appropriately in clinical practice. A number of them are listed here, and we spent some time reviewing resources from the advisory board, the CDC, AHRQ, Intermountain Health, and the VA and DoD. It took us a while to sift through that research. We agreed that it was best to focus on a national standard guideline. So we selected the CDC's 2016 guidelines for prescribing opioids for chronic pain. As we reviewed these guidelines, we also were cognizant of the fact that it, on average, takes 17 years for best practice guidelines to find their way into clinical practice, and that there's often low accessibility within clinical workflows, such as diagrams, websites, pocket reference cards, and so on. So we sought to do our part to accelerate that process and offer some recommendations for how those clinical guidelines could be implemented using health IT tools. Like I said, our team selected the CDC guidelines. My hope is that some of the participants on this call are familiar with these, but if you haven't come across this, it's a fantastic resource. It offers 12 targeted recommendations for the appropriate use of opioids within a larger pain management strategy, and it's specifically formulated for patients with chronic pain, but we thought it was a great starting point for how opioids can be used in clinical practice. We picked those apart one by one. I thought through for each of those 12 recommendations, and we'll talk about those in just a moment, what the role of HIT was, and our team ultimately produced this opioid guideline, implementation guide for electronic health records, and we released this under the EHRA. I believe it was towards the end of 2018, and it's available on our website. We want to show you some of that work and talk about what's included in that guide and share some ideas for strategies you can use today. We designed this to be a low lift, meaning that it was something that you can take right off the shelf and hopefully deploy without too much design and preparation work, making suggestions that can be operationalized now and operationalized iteratively with suggestions that can be built one upon another. Even though some of these things are basic, the goal is for us to offer solutions that can help improve quality and safety and the patient experience. Some of our other goals were to introduce or offer suggestions for clinical decision support to have clinicians make informed decisions at the point of ordering and increase their adoption of information technology tools. These these suggestions also form the basis for suggestions for our health IT vendor community for some capabilities that may be able to be developed to better support the clinical workflows. So it's targeted both to hospitals and healthcare providers, as well as to our health IT vendors. We have a list of organizations that are intended targets of our guide, and we intentionally excluded some populations because the guidelines don't apply to palliative care, sickle cell anemia, or cancer treatment patients. But by and large, this does cover the majority of workflows. The CDC guidelines, like I said, offer 12 specific recommendations, starting with opioids not being a first-line therapy, tracking pain and functional goals. Then there's some guidance on how to evaluate the need for opioids, how to prescribe opioids, and then how to monitor your patients and ensure that they're complying with the guidelines and the plan of therapy that you've established. We offer commentary on all 12 of these guidelines, and we'll dig deep into about 4 or 5 of them because we don't have time today to discuss them all. But these should be guiding the physician's selection of opioid therapy and the course of treatment that would be established to use opioids. And then we matched those 12 recommendations with a number of health IT technology solutions based in the EMR. Some of them may come to mind naturally, such as electronic prescribing of controlled substances, utilizing order sets and decision support, patient education, and things like that. Some of them are emerging technologies or perhaps less obvious. Things like population health tools to keep track of all your patients on opioids at once, utilizing screening assessments for patients that may be showing signs of opioid misuse, and applying predictive analytics to try to identify which patients are at a higher risk for opioid misuse and which ones may end up exhibiting either drug-seeking behavior or having opioid use disorder or substance use disorder. So we picked and chose from this list of technology tools and matched them with the appropriate recommendation statements from the CDC. Let's, like I said, dive into a few of these with a little more detail and give you an idea of some of the strategies that you can use to apply these guidelines in practice. The first one, again, was opioids are not a first-line therapy, and the CDC recommends non-pharmacologic treatment and non-opioid therapies for chronic pain. When it comes to the EMR or EHR, this is naturally a place where we can leverage order entry and treatment selection, guiding clinicians with both active and passive decision support towards these non-pharmacologic therapies to start with. So patients may try things like physical therapy, they may try epidural steroid injections, they may try intrathecal pumps, they may try cognitive and behavioral therapies. There's lots of alternatives that you may try before moving on to opioids as a second or third line approach. So what can organizations do from the IT perspective? Well, first, the CDC offers more targeted list of non-pharmacologic treatments that can be used for the most common sources of pain, and it offers some suggestions for things you can place in order sets. Again, fairly straightforward, but you can adopt advisory text in order sets with reminders on how to use these therapies and what order to choose them and put them into effect. Passively, you can organize your order sets so that opioids fall at the bottom of the list or perhaps under drop-down headers so that you have to go digging for those choices because those are the heavy hitters and you don't want to start with those first. And then active decision support can remind you if non-pharmacologic therapy has not yet been tried or suggesting alternatives if applicable. One thing you'll notice with these recommendations, we intentionally structured these to go from easiest to most difficult to implement so that you can work your way down the list and iteratively build on these over multiple cycles of process improvement. Jumping ahead to guideline number 5, using the lowest effective dose is recommended by the CDC. And in this recommendation statement, they introduced the concept of milligram morphine equivalents and recommend that opioid therapy begin with dosages less than 50 MMEs per day. If anyone is unfamiliar with the concept of MMEs, this is a measurement of how much opioid therapy a patient is on if you were to convert all of the patient's current opioid prescriptions into an equivalent amount of morphine, which is the gold standard for pain management. The CDC offers some guidance on how that should be done, which is starting with the total daily amount of each opioid the patient takes, and then multiplying that by a conversion factor, which they supply to get a, in my mind, roughly equivalent amount of morphine as if the patient was only taking morphine. So an example here is if the patient is on oxycodone 5 milligrams, 1 tablet every 4 hours. To do the math, you would multiply the 5 milligrams times 6 doses per day times the conversion factor you can see towards the bottom of that table, which is 1.5, that gets you to 45 daily MMEs. You can see that this is just for one prescription. That's not that difficult, but across multiple prescriptions that can involve a fair amount of math, and keeping track of that level over time can be difficult. We saw this as a natural space where health IT tools can make a difference by automatically doing those calculations and also letting you know if the patient may be at or exceeding the safe limits of 50, 90, or 200 MMEs as recommended by the CDC. So several things that you can do with this. Educating your clinicians on utilizing MMEs in pain management and how to use them in clinical practice is the first step. Second would be to implement an MME calculator solution, which would enable your clinicians to monitor those MME levels and check to see if they are at or exceeding the CDC risk thresholds. We recognize that not every EHR vendor has an embedded MME calculator, but there are other approaches to calculating MMEs. There are online websites that will do it for you, and the CDC also offers a free iPhone and Android app that can do the math based on quickly punching in the patient's opioid prescriptions. So there's various ways to do this, and you can also code reports that can do that on the back end. So making clinicians aware, getting them tools that can get the calculations done for them, and then tracking to see if they exceed CDC risk thresholds. And finally, using unit or service dashboards that can monitor MMEs in aggregate with the ability to drill down to both provider level and patient levels to track overall opioid utilization. That way, you could quickly zero in on providers that routinely prescribe more than 90 MMEs, and there are some emerging quality measures around that metric as well. Again, we're bouncing between different guidelines just in the interest of time. Guideline number 7 talks about evaluating the benefits and harms of opioids frequently. You may think this one is more about the conversations that a clinician is having with their patient, and more of a workflow step than a technology step, but there are steps that EHR can play in improving this recommendation. We recommend that EHRs be used to prompt physicians to consider the benefits and harms of opioid therapy at various points, both during the ordering process and during the follow-up process. We also recommend the use of population health tools such as dashboards and registries to monitor all your patients currently on opioid therapy. And this is a tool that can make sure that patients aren't falling through the cracks. So this would be patients that the CDC recommends you follow up every 3 months or more frequently. So patients that haven't been to see their physicians in more than 3 months, care quality teams can monitor those patients using EHR tools. Other ways EHR can help, just using reminder text in order sets that remind providers to evaluate benefits and harms of extended opioid use more frequently. The CDC has a nice prescribing checklist that consolidates all the things that need to be evaluated the next time a patient returns for a follow-up visit, and encourage them to use that as a supplemental material to make sure everything's being reviewed when the patient returns. And then, as I said, dashboards that can find all your patients on opioid therapy, check your last urine drug screen, check your last opioid treatment agreement, check your last or the next upcoming date for follow-up. Make sure that patients aren't just going for months or even years without checking back in with their providers. Guideline number 9 encourages organizations and physicians to review PDMP data. The term PDMP refers to Prescription Drug Monitoring Programs, and in the state of California, that is better known as the CURES database. This is, as many of you know, a state-level database that aggregates all prescriptions for controlled substances as reported by pharmacies, and makes that information available to providers. It is a relatively new technology, but EHRs are now able, in many cases, to integrate electronically with PDMPs and display their data within clinical workflows. There are several networks out there that provide the backbone of that integration, the best known as APRIS. There's also CRISP and Logikoi and others, and that can facilitate getting that information out of PDMPs and into the EHR. Obviously, this is a best practice statement as we recommend from our organization. If possible, and I know that the availability of an interface to the CURES database is rather new, and my understanding is that there are pilot sites working on this now. But as soon as it's generally available, we of course encourage everybody to pursue an interface so that that data can get right into the hands of the clinicians, and they don't have to go logging in through the separate state portal to access that information. We also recommend educating providers and pharmacists on the need to query the PDMP before prescribing opioids, and develop some documentation templates where physicians can not only attest to reviewing the PDMP, but also record any findings, such as if patients are doctor shopping, which can inform the next course of treatment, and perhaps justify if you need to no longer pursue opioid therapy, why that may be. The last one that we'll review in some detail is guideline number 10, which is a recommendation to use urine drug testing. This one may sound pretty straightforward. Clinicians are encouraged to use urine drug testing both before starting opioid therapy and at least annually after starting opioid therapy. And for patients at a higher risk level, they may be encouraged to use this strategy more often. So again, you may think, okay, that's not so hard, we'll just order urine drug screens. But there are several ways that EHR technology can actually help with that process. One thing to consider is that urine drug screens can be implemented either at the point of care using a quick cup analysis, or they can be done in a lab. So the first step is to determine what the protocol your organization uses for urine drug screen, and see if it's consistent between different care settings. Those test results do have to be documented in the EHR, and not every organization has a place to record point of care test results, so make sure that that's understood and work out a workflow for nurses and physicians in an office setting to capture that information. Next, we recommend using scheduling software to book follow-up urine drug screenings, again, to make sure that patients don't forget about coming back to return for that. And then use patient engagement tools to send reminders to patients when their urine drug screenings are near or overdue, or both. And then automatically notifying physicians if patients missed their testing dates. Next level up would be to, again, use population health tools or dashboards to monitor patients who need multiple urine drug screens or that have screened at a higher risk level. And then finally, use clinical decision support at the point of ordering opioids if a prior urine drug screen was positive for illicit substances. This can be helpful, especially in larger care teams, or where that last urine screen was not part of the last visit. So all these strategies, building one upon another, you can get progressively more sophisticated about making sure that these things are done and done appropriately and on a regular basis. So that's a sampling of some of the recommendations that we made in our implementation guide. Another thing that we did in an effort to try to help the broader health IT community and the clinical community as well was to curate a list of ICD-10 and SNOMED codes that represent both patients who have chronic pain on their problem lists, or also we didn't talk about recommendation number 8, which is to monitor patients who are at an elevated risk of opioid-related harms. But we've curated a list of those codes that would identify those patients, and that includes patients with sleep-disordered breathing, patients with renal or hepatic insufficiencies, patients with mental health conditions, patients with currently have substance use disorder, and precautions for patients who are geriatric patients or pregnant women. So for all of those categories, our team did some research and identified these codes that would find those patients, and our hope was that those could be utilized in a plug-and-play approach to develop reporting tools, develop population health tools, to develop any EHR-based solutions that would help identify those patients and then use that for process improvement or for bringing those patients to the attention of the physician. So our intention here was to make it easy to download this guide, plug those in, and then use it for your own purposes to improve your learning. And hopefully we've saved you the research of having to curate this list yourself. So this guide is now available from our website, where we hope that it's useful to everybody on the line. We encourage you to use it, share it with your opioid stewardship teams, or use it to help launch one if you don't have one already. We understand that not every EHR is able to make use of every recommendation that's present in the guide. That's okay. Our hope is that it can help inform future direction, both again in the hospital and in the clinical community, as well as in the health IT space. And it's our roadmap and our recommendations for how to move forward on this in the future. So we hope it's useful to you and encourage you to share that with your teams. Before we pause for questions, I also wanted to turn things over to David Bushafero, who's done some terrific work with his technology and standards team and has developed some additional resources for the EHRA that we'd like to share with you as well. So Dave, I'll turn it over to you.
Thanks, Dan. Could you just move the slide for me?
Yes.
Thank you. Before I start, I did want to just say that I believe on the line is the co-chair of this group, Caitlin Fontaine, who really helped an enormous amount in helping pull this together. So our group, the Technology and Standards Group, when we got together, we really wanted to try to get a lay of the land and see where technology was around PDMP and EPCS, the electronic prescribing of controlled substances. So what we did was we really did an evaluation of the current state of each of those programs, state by state. What we found were that there were tremendous amounts of variation in the use of PDMP and EPCS at state levels. And I'll talk a little bit more in a minute about the barriers that they created after I go through some of the things that we actually looked at. But I know most of you probably know that the PDMP program has a single vendor in the majority of the country. not all the country, but I believe 47 out of the 51 PDMPs that are in existence are members of one company. And even with that scenario, we were finding many differences as we went state by state. As we go through this, it's important to note that one of the things when we're talking about PDMPs and EPCSs is that they're really controlled at the state level. Those programs come out of the federal government from a standards perspective, but there's not a lot of control at the federal level over how each PDMP is incorporated, or up until recently that every state needed to have an EPCS in place. It was only in the last year where legislation is now requiring that the EPCSs are in every state and they're required. And we'll talk a little bit more about that as we go along here. So when we studied the EPCS program, we just looked at a couple of things. Who had mandatory prescribing practices, and there's not a lot of them. There were only 7 at the time, and really only New York was at a level where electronic prescribing was really in the higher percentage. They were about 94, 95% at the time that we looked. I think they're at 97 now. And what we found was that, and this is probably not a surprise, that those areas that had mandatory prescribing really did use it, and they had very high numbers of pharmacies that were accepting electronic prescribing. And it wasn't a matter of the technology at that point. It was just that there was no requirement to do it, so people weren't doing it. And so now states have until 2021, I believe it is, to implement their EPCS program, and they're moving forward with it. So we're hoping that in a couple of years, every state will be moving forward with the EPCSs, and that part of this issue, it will be taken care of. And the reason why it's so important, because that's obviously the first place that information starts to be gathered around the prescribing of controlled substances. We then turned our effort to the PDMP program, and we looked at a number of different pieces of the PDMP program. We looked at what types of data had to be reported. We looked at when that had to be reported. We looked at who was required to report in that particular state. We looked at various regulations within the state that had to do with sharing of data within the state. So who in the state could actually see the data? And we looked at law enforcement, we looked at providers, we looked at individual practices, we looked at research, we looked at 6 or 7 different areas as to who could have access to this data. We then looked at the interstate sharing and what states shared their data with other states, because as most of you probably know, that one of the issues is really this drug shopping, where individuals will go from one state or one doctor to another, and it's got sophisticated enough where they go from one state to the other and looking for a prescription. And you wonder how this is possible, but because even though a state may have a PDMP program in place, in some states, the time required to report your medication to the PDMP range everywhere from Oklahoma being 5 minutes, but they were the biggest outlier. Most are 24 hours or the next business day. So if you think about it, someone could have gone to the doctor in the morning of a Friday morning, and that information would not have been required to be reported until sometime by Monday. And that period in between, someone could have had 2 or 3 scripts put in place at that time and been able to, acquire medication that was a controlled substance. We also looked at EHR integration, and we looked at what states had EHR integrations in place, what types of integrations those are, and of those integrations, did some states promote it? Did they offer funding? Did they build APIs or other reporting structures in place so that it made it very easy for an electronic health record and a practice to come in and say, we want to direct connect with the EHR? The benefits of that are pretty obvious from a workload perspective, because we all know that if a clinician has to leave their existing system and go into another system, it makes the workflow extremely difficult. So some of the barriers, some of the issues that we found were that with all of these variations in the way PDMP was integrated or was actually operationalized in each state, it created a lot of barriers. There wasn't a common data set of information that a clinician knew they were going to see. They weren't aware of when that information actually was put in, so they didn't know how up to date that information was. Oftentimes, they were unable to receive information that may have came from another state. So if this person had lived in 3 states in the last 3 months, it's possible that this person was not, you're not getting the entire picture. And so their ability to be able to make clinical decisions became very hard. In addition to that, for clinical development, for clinical support development, for things like Dan had just talked about that actually have the same level of value, it's important that the most up-to-date and accurate information is in that record so that clinicians feel comfortable that the information or the support programs that they're looking at are accurate and are telling them the current story. And so we have available for you, if you're interested in seeing this, the actual landscape that we've done. And I will tell you up front that this landscape is constantly changing. With all the emphasis on the opioid crisis right now that's taking place, a lot of states are making changes to their PDMPs. I should also add, before I move on to the next slide, that one of the other things that we did find, and this is starting to consolidate a little, but that the PDMP program resided in various different areas of state government. In some places, it was the Human Services Agency. In others, it may have been a control agency that's in charge of these types of programs. And in other areas, it was the justice law enforcement that was in charge of these. And, depending upon what state you're in, the reason for the development of the PDMP may have been different. In some states, it was around law enforcement, and in others, it was more around trying to track controlled substances, and then in others, it was really to try to build a database that could be used for healthcare purposes. So there were various ways that this came about and this program actually developed, and that's part of why there's so many different variations of this program. Dan, could you move on? So one of the tasks we took on after looking at the data sets, and I will say that the companies that develop the PDMP program, they use a standard set of data that states are able to select. But what we found was that not every state was collecting the same data, and it made it very difficult, or it makes it very difficult to really support the clinician when they may not have all the necessary information in front of them. And so what we did was to try to address this lack of standardization of information that wasn't available within the EHR. We developed, with the help of a number of clinicians, physicians, and other healthcare professionals that work with the HR member companies, we identified what would be an ideal data set. And this minimal data set, we felt, would have the most beneficial impact on clinical decision support. It was those data elements that a clinician actually looks at when they're trying to make a decision on how they'll use medication to address this individual's pain or other issues. And so we're hoping that we're going to be able to work with various federal agencies and state agencies. We've already presented this to a number of federal agencies. We recently shared it with a group of stakeholders, state stakeholders at this past year's HIMSS conference, so that we can start to develop a standard that will allow for this information exchange where it's valuable to the clinicians. And again, this is available for download. We'd be happy to share it with any one of you and welcome your opinions. So our task force is ongoing. We're continuously updating the work that we do. And like Dan's group, we're looking at the next area that we're going to attack is, as all of you know, the opioid crisis is complex, and the need for standardization of information is critical. So I believe we're going to open it up to questions, unless Lee had something to add. Or
no, that's right. Time for questions.
No, I'm sorry. Actually, this is David Ford. Not just yet. Before we go on to questions, we will come back to that. And there's information up on the screen right now for how you can get in touch with Sarah Willis Garcia at the EHR Association for more information. You can also go to their website, EHRA.org, for downloading all of this fantastic content that they put together. But before we break for questions, I did want to jump back in and talk just a little bit today about what is going on specifically here in California, because like most states, there is a lot of activity here in California around the opioid crisis, and much of it is actually becoming health IT related. So I will go through this very quickly before we open up for questions. But just a couple things. It was referenced earlier in one of the earlier slides about the API, the interface for the Cures database, which was published last year. It was actually published October 1 of 2018 based on a bill that then Governor Brown signed in October 2017. And what it will allow for is that for the first time, health IT systems, so either some vendors who are doing it directly, or, as we'll talk about more in a moment, health information exchanges that want to, will be able to interface directly with the Cures database and download data directly into the EHR system. As I mentioned, the interface was published October 1 of last year, along with a memorandum of understanding that HIT systems had to sign in order to access it. My understanding is at the moment, everyone's still working to get this up and running. It's pretty complicated, not the least of which because here in California, the Cures database is housed within the Department of Justice, not in the health, in the HHS agency. So there's a lot that's still being worked out, but very soon that interface should be up and running. And it connects, very importantly, to something that I hope everyone is aware of, which was the very next day, October 2nd, 2018, it became mandatory to consult the Cures database when prescribing Schedule 2 to 4 controlled substances. So this was very closely tied to the development of the interface. Attorney General Javier Becerra had a long time to sort of think about when he wanted to start this, but he ramped it up starting October 2nd to go along with the development of the tools to make it easier to consult the Cures database. So I do want to make sure everyone is aware, and there's a link up on the screen if you want to download a flyer directly from the medical board about mandatory use, how it works, and what it means for your practice. And then one more thing that I will run through, which is very soon here, California is going to be starting a new program called CalHOP, the California HIE Onboarding Program. And this was a program that CalHIPSO, the California Medical Association, Blue Shield of California, and many, many others worked together to fund. So last year, we got a $5 million allocation from the state legislature for HIE onboarding, which will be matched 9-to-1 by the federal government, giving us total a $50 million program to help providers onboard to health information exchanges. So right now, DHCS is currently working to secure the federal approval, because obviously we need their approval for the $9 of their dollars for every one of our dollars that we're planning to spend. And then the program should begin somewhere late spring, early summer of this year, and will run through the end of federal fiscal year 2021, which is September 30th, 2021. And now why this all matters to Cures is because, as I mentioned before, all of the health information exchanges are working right now to try to connect to that interface to the Cures database, which was published last year. Under CalHOP, the health information organizations are actually going to be eligible to receive funding to connect to that API. So if you, in your practice, have ever thought about getting onto a health information exchange, joining your local community HIO, and hopefully you have, just know that starting very soon, they're going to have funding to have that use case of the connection to the Cures database available to them. And then one last thing, especially for our folks on the phone who are at clinics, hopefully you're aware of the medication-assisted treatment activities that are being managed by the Sierra Health Foundation. They have an open application right now where you can receive funding to expand or enhance the medication-assisted treatment activities that are going on at your facility. I recommend everyone check out MATaccesspoints.org for more information about that. There's a bunch of money that has come from the federal government that is flowing down through the state to the Sierra Health Foundation, and they have a process right now for distributing it. And now we will go to questions. So let us look just real quickly at what is in the chat box. One thing that, and it gets asked at every webinar that we do, so I'll bring it up, folks ask about the slides. And just so you know, we are willing to send out the slides if you want to send a note to info@calhipso.org. But you can also, if you want to go back and watch the recording of this webinar, we post them on the CalHIPSO webinar channel on YouTube. And we try to very quickly after the end of every presentation have a link to our YouTube channel up on the CalHIPSO website, calhipso.org, under webinars. So let's see what else is in the... So one of the questions that has come up here is, and maybe some of the folks from the EHR Association can weigh in on this. Someone is asking about examples of platforms that are interfacing with the PDMPs. He or she says, I think I heard APRIS and one other.
David, do you want to take that one?
Sure. Most of the PDMPs are operated, as I mentioned, by a state. However, the software behind those programs in many states, actually in the majority of the states, those are operated by APRIS. The other ones are the software is developed by APRIS, and the state operates that program. The other ones, most of the other ones are home developed, created by within each state. There's a couple of states that use a portion of the APRIS and a portion of their own product to develop. I'm not, Lee, I'm not familiar with any other major company that's created them. The only ones I know of that are non-APRIS are really developed by themselves. So if anybody else.
What about Dr. First?
Well, Dr. First has one. Yes, they have one that's in a state. It's a little bit different than the traditional PDMPs, but they do basically the same thing. That's a good point. They accomplish the same goal. They're capturing the data from the pharmacies and creating a centralized database.
And Dave, this is Dan. I had in my presentation I had mentioned CRISP, which I believe works with the Maryland PDMP, and Logicoi, which I believe works with the Nevada PDMP. So I think there's a handful of other smaller vendors out there.
Yeah, they are, and those are more. They're developed particularly for that state, as you mentioned, Dan. Right. Those are like state developed programs, and they've used some smaller vendors.
And just in case the questioner was here in California, this is David Ford again. The interface that was developed by the Department of Justice, they developed in-house. So I know a lot of the folks who have already been mentioned here are working to connect to that interface, but the interface Department of Justice built themselves.
Yes.
It looks like that is it for questions. I will mention this is usually the point in the webinar when I talk about what will be next month's webinar. We're not exactly sure what it will be yet this month, but I did want to mention right about the time when we would be doing next month's webinar, CMS has declared National Care Transitions Awareness Day to increase the awareness and importance of value of safe and effective care transition. So we're looking at building something in that space. It is a very important topic and one that has been heavily influenced by health information technology. So with that, I think we will wrap up our session. I would like to thank our colleagues from the EHR Association for being on today's call and being our faculty today. This has been fantastic content and a whole lot to think about. And I hope everyone will visit their website and download all of their content. And I will mention just one more time as well, May 13th of this year, that is the CalHIPSO conference here in Sacramento. And if you've been thinking about attending our conference, I will just mention you've got about 24 hours from right now to get in under early bird pricing, and after that, the price goes up by $100. So go to calhipso.org/events, and we will hope to see you here in the capital city in May. All right. Thank you, everyone, for your time. And with that, we will end the recording.
Thank you.
Thank you.